Okay, so let us start looking at these questions. Let me just check if everything is all right. Some issue, I'm not able to see it live. Okay, yeah, so everything is all fine. Okay, so question number one. So let us look at this question. What does this say now? Question one, a patient presented with pancytopenia, visual loss. So patient is having presented with pancytopenia, that is a history given to us, and there is a visual loss that has been given to us, isn't it? So pancytopenia, visual loss, and further, what else has been given to us? Pancytopenia, visual loss is there. Bone marrow biopsy is as given below. What is the likely diagnosis? So options are myelofibrosis, osteoporosis, osteopetrosis, osteogenesis imperfecta. So look, what am I seeing in this bone marrow examination here? So I can see this is the cortical bone. Yes, correct. This is your cortical bone or cortex. I can label it. This is your cortex and this should be your medulla, isn't it? This will be your medulla. And in the medulla, I'm able to see, look, this pink material that you are seeing within the medulla, this is all bone. Osteoid is there, isn't it? So in the medulla, there is a bone that is there. That means even the medullary cavity is filled with bone. If the medullary cavity is filled with bone, the diagnosis, what is the diagnosis? Osteopetrosis. So what exactly happens in osteopetrosis? Tell me, guys. Yes, you can use the chat box and please tell me what happens in osteopetrosis. Good evening. Good evening. Tell me what happens in osteopetrosis. Osteopetrosis, there is a lack of, yes, there is lack of osteoblastic or clastic activity, which is not happening. Yes, there is lack of osteoclastic activity. That is why there is excessive bone formation, isn't it? Excessive bone formation will eventually lead to what? So there is an excessive bone formation which eventually leads to, yes, good evening, good evening. So excessive bone formation, even medullary cavity also filled with bone. Because medullary cavity is filled with bone, patient is having pancytopenia, isn't it? Yes. And also further, one more thing. So because there is a pancytopenia happening, very good. So deficiency of osteoclastic activity is there, right? Okay, because of that excessive bone formation, even the foramina will also be deficient, or they will be filled with bone. Because the foramina are filled with bone, you will end up finding obstruction symptoms, right? Especially cranial nerve obstruction symptoms will be seen. Yes, cranial nerve obstruction symptoms will be seen, right? Yes, so that is your question number one. Question number two, let us look at question number two. Okay, so history says there is a genetic disease running in the family. The clinical picture is as given. What is the likely pathogenesis of the disease? So examiner is asking what is the likely pathogenesis here. Okay, so this is a clinical picture of the disease. Can you tell me now what is the problem here? Yes, so what is your diagnosis? This is your osteogenesis imperfecta. How do I diagnose this osteogenesis imperfecta? Oh, sorry, not osteogenesis imperfecta. So what is your diagnosis here? Sorry. Yes, what is your diagnosis? Very good. Achondroplasia. Achondroplasia. Osteogenesis imperfecta clinically will be having what? Osteogenesis imperfecta will be clinically having blue sclera, isn't it? Yes, that will be having blue sclera. This is your, yes, yeah, so this is your achondroplasia. Why? Because the long bones are not growing well here, isn't it? You can see the torso is like an adult, but fully grown up, whereas the bones, long bones, are very short compared to this fellow. This fellow is normal; he's not affected, so he's a normal person. These two are having the disease, isn't it? Achondroplasia. What is the problem with achondroplasia? Achondroplasia, option given, loss of function of FGFR3, deficiency of osteoclast. That is not the case. Deficiency of osteoclast is your what? Osteopetrosis, isn't it? We discussed just now. Deficiency of type 1 collagen, also not. That is your osteogenesis imperfecta. So loss of function of FGFR or gain of function? Gain of function of FGFR. Because gain of function of FGFR is there, there will be premature closure. Growth cartilage cannot grow. And because of that, there will be long bones will not be growing. That is what is the pathogenesis of this condition. Isn't it? Achondroplasia. This is an autosomal dominant condition. Next question, question 3. The term involucrum refers to necrotic tissue in osteomyelitis. No, this is not necrotic tissue in osteomyelitis. What is it called as? Sequestrum. This is your sequestrum. Necrotic tissue is sequestrum. New bone formation. No, that is also new bone formation. Yes, that is a correct answer. That is your involucrum. So whenever there is damage to the bone happening, and there will be, yes, there will be new bone formation that will be there, right? Yes, pus draining from the sinus. No, from the skin, that is called sinus. Fracture without trauma. No, that is pathological fracture. So that is your next. Next is, which of the following, simple question, one liner question, which of the following is not a bone forming tumor? Which is not a bone forming tumor? Okay, tell me now. Osteoclastoma, osteoid osteoma, osteoblastoma, osteosarcoma. Osteoclastoma is the correct answer. Osteoclastoma is not a bone forming. In fact, it's a bone destroying tumor. It is also known as giant cell tumor of bone, and the origin is unknown origin, isn't it? This is your unknown origin tumor. Unknown origin tumor. Now the hypothesis is it arises from osteoblastic progenitor. It arises from osteoblastic progenitus. That is your no, this is not predictor series. This is questions from systemic pathology questions. So we are talking 4 chapters here. Okay. Next, bone soft tissue. Okay, question number 5. A lengthy question. How to approach such a lengthy question? Last line. Always for approaching a lengthy question, start with the last line. Biopsies as given below and likely diagnosis they are asking us. So what are the options given to us? Look at this. Osteosarcoma, Ewing sarcoma, osteoclastoma, osteoblastoma. So basically there are tumors that are there. Let me see the question now. What is the question saying? Okay, 28-year-old woman presents with left knee pain for several months that worsens with activity. Okay, there is no history of trauma. Examination reveals swelling and tenderness over proximal tibia. So there is a swelling and tenderness that is there. X-ray reveals lytic lesion. So very, very important, lytic lesion in the epiphysis. So that means there is no bone formation. It is unlikely to be a osteosarcoma, isn't it? Lytic lesion is there, whereas osteosarcoma will be both lytic as well as bone forming one, right? So bubble appearance anyway. So you will study this subsequently in radiology. So bubble is one of the characteristic appearances of a giant cell tumor. And look at this. This is the histology. What is the histology showing here? Histology is showing these are your multinucleate giant cells, isn't it? So these are your giant cells, and these are very diagnostic of giant cell tumor or osteoclastoma. Remember, these are reactive giant cells. They are not neoplastic. The neoplastic giant cells will be mononuclear, which are yes, which are osteoblastic progenitus, which are osteoblastic progenitor. Okay, next question. Let us look at this question now. Question number 6. Let me see what is this question saying. Okay. 11. Okay, last line, lengthy one. Biopsies as given below. What is the likely diagnosis? Osteosarcoma, Ewing sarcoma, osteoclastoma, osteoblastoma. 4 options are given. Okay, let me see now. Again, it's a tumor. Same 4 options are there. 11-year-old girl complains of right thigh pain. Okay, childhood onset tumors. I start thinking of osteosarcoma or even a Ewing sarcoma, isn't it? Okay, low-grade intermittent fever for the past 1 month. Okay, there is also fever there. Okay, that might be reactive as well, but no options. All of them are tumors. A tumor which will present like a reactive or inflammatory condition more likely clinically looks like Ewing sarcoma, isn't it? Her parents say she limps occasionally. Physical exam reveals slightly warmer, again looking like inflammatory condition. Remember, Ewing sarcoma clinically mimics an inflammatory condition, isn't it? Okay, and there will be tenderness in the right mid shaft of the right femur they have given us. Okay, there is tenderness in the right femur. Biopsies has given below. What are you seeing on biopsy? Very characteristic. Okay, these are all small round blue cells, isn't it? I am seeing small round blue cells. So this is a small round blue cell tumor, and I am seeing Omer right rosette. Omer right rosette. Omerite rosettes, very characteristic of Ewing sarcoma. Ewing sarcoma or primitive neuroectodermal tumor, PNETs. Ewing sarcoma or PNET. Next question number 7. Mutations associated with osteochondroma. Osteochondroma mutation are EXT1 mutation. EXT1 and EXT2 mutations are there. Osteochondromas, right? Yes, that is your mutation associated with osteochondroma. Next, which of the following is characteristic of Ewing sarcoma? Characteristic of Ewing sarcoma, MYC2 positive, translocation 922 and pass negative, all of the above. It is pass negative is wrong. It will be pass positive, by the way. So that is why all of the above is also ruled out. So now MYC2 positive, translocation 922. It is not 922. It will be translocation 1122 is a characteristic of Ewing sarcoma, isn't it? Not translocation 922. 922 is for Philadelphia, CML, isn't it? Yes. So in this MYC2 positive, MYC2 is also called CD99. That will be positive in Ewing sarcoma. MYC2 positive, right? Next, let us look at this question. 7-year-old boy presents with rapidly growing painful mass in the orbit. Orbital tumor is there. Painful mass in the orbit. Biopsy reveals small round blue cells that are positive for desmin and myogenin. So the moment they say they are positive for desmin and myogenin, these are markers of muscle. So it is a muscular tumor, and desmin myogenin for both desmin is for both smooth and skeletal muscle, myogenin is more for skeletal muscle, and it's a skeletal muscle tumor, isn't it? Myogenin is for skeletal muscle. So the diagnosis will be rhabdomyosarcoma, rhabdomyosarcomas, and they will be periorbital in nature. Yes, correct. Another round cell tumor in the periorbital region could be even your retinoblastoma, but that will not be positive for desmin and myogenin, right? Retinoblastoma is also a round cell tumor. Ewing sarcoma is also small round cell tumor. Lymphomas are also small round cell tumor. Synovial sarcoma is also small round cell tumor. Okay, next question. Question 10, lengthy question. Likely diagnosis. So what is the diagnosis? Nodular fasciitis, fibromatosis, lipoma, rhabdomyosarcoma. Okay. 28-year-old woman develops a rapidly growing tender forearm mass over past 3 weeks. Histology shows a cellular myxoid lesion with spindle cells and mitosis, but there is no ATPR. This is very characteristic of nodular fasciitis. Nodular fasciitis for very long was considered as an inflammatory condition. That's why we are using the word fasciitis. But it is now considered as a neoplastic because these are monoclonal cells are there. That is why it is a neoplastic, but it is considered as benign neoplasm. And usually nodular fasciitis will regress. Few weeks later, the lesion is regressing on its own. Nodular fasciitis. Very characteristic. It looks like a very malignant tumor with high mitosis, but there will be no ATPR, remember. And usually there will be an incidental history of some trauma will be there. Okay. Some history of trauma will also be there. Okay. Yes. Next. Question 11. Okay, which chromosomal translocation is most likely to be seen? Okay, which chromosomal translocation most likely to be seen? Translocation 213, 1122, X18, 922. Okay, so if you want, you can translocation 213. Where is translocation 213 seen? In liposarcoma. 1122, Ewing sarcoma. X18, synovial sarcoma. 922, CML. Right, this is how I will be looking. I have to now diagnose which one is it. Okay, let me look at the question now. What is the question saying? Okay. Yes. 30-year-old man presents with deep-seated, yes, mass near the knee. Histology shows biphasic pattern of spindle and epithelial like cell. This is very diagnostic of synovial. Synovial can be showing biphasic, isn't it? Yes, biphasic synovial. So this is your synovial sarcoma. Next. Yes, let us look at this question now. What is this question? 45-year-old woman presents with slow growing painless mass in the forearm. Histology is as shown below. Familial tumors are associated with. So this is the histology. What you are seeing, look at this. Yes, you are seeing these are nucleated areas, and in between there is a Verroque body. What is a Verroque body? Verroque body are nuclei free zones that are there. So look at this. This is your palisading nuclei, one row of nucleus, another row. In between there is a Verroque body. Verroque bodies are very characteristic of schwannoma. So my diagnosis is schwannoma. So schwannomas are associated with neurofibromatosis to NF2. NF1 is associated with neurofibromas. Yes, NF1 is associated with neurofibromas. Schwannomas and malignant peripheral nerve sheath tumor, NF1. NF2 is associated with schwannomas, right? And meningioma. Question number 13. Shredded carrot collagen. Shredded carrot collagen appearance on histology is seen in, yes, this is very characteristically seen in neurofibromas. And these are positive for CD34. Remember, CD34 positive, even S100 can also be positive. S100, although characteristically positive in schwannoma, but it can be positive here also. Shredded carrot shredded carrot collagen. So that is your, once you shred the carrot, there will be long slices of carrot, pink color appearing or orangish appearing. That is how collagen appears. Next, question number 14. Okay, let us look. Which of the following investigation will help in arriving at diagnosis? Okay, so what will help in arriving at the diagnosis? Blood culture, cranial biopsy, CSF examination, MRI of neck. Okay, so a patient presents with fever. Patient is having, yes, fever, headache, neck stiffness. Now he has vomiting and altered sensorium. CNS manifestation, vomiting probably due to increase in intracranial tension. Neck stiffness is also there, very characteristic. All these are very characteristic. I am clinically suspecting it to be what? Meningitis, isn't it? Meningitis. So investigation for meningitis will be CSF examination. CSF examination, right? Yes. CSF examination of a patient. Next question. CSF examination of a patient suspected of meningitis shows slightly increased pressure. Look at the word they have used, slightly increased pressure. Increased pressure is there. That means there is some edema is there, because in CSF edema, the CSF more secretion will be there. That's why pressure will increase. Then slight increased protein and decreased glucose. The moment glucose is decreased, definitely I am suspecting what? If glucose is decreased, I will suspect some bacteria, because they will consume glucose, isn't it? It is not viral, and it is definitely not normal also, right? So it is not viral, it is not normal. Okay, so now is it bacterial or tubercular? Tubercular is also bacterial, by the way. So very, very important. In a tubercular, there will be, because of chronic inflammation, there will be cobweb formation. There will be, the CSF pressure will be extremely high. So slightly increased pressure is there. That is why I rule out of what? Tubercular. Tubercular will have very high CSF pressure. Very high CSF pressure will be there. So that is what is differentiating. So glucose, protein will be increased in all condition, right? So glucose, and one more thing that can differentiate, by the way, they have not given in the exam here, neutrophil. Abundant neutrophil, definitely bacterial. Less neutrophils, then it will be what? More of tubercular, right? Yes. So that is how you will approach. Question 16. Okay, let us look. True about CNS tumors. Mostly arise from glial cells. Mostly arise from glial cell. Yes, this is a true statement. So tumors in the CNS are not from the neurons, they are rising from the glial cell. That is true. TNM staging is not done. That is also true. Why it is not done? Because there is no lymphatic no lymphatic spread and no hematogenous spread also. So that is why TNM staging is of no use in CNS tumor. Instead of staging, we do grading, and grade 4 are considered malignant. That is also true, and that is why answer all of the above. So in CNS tumor, all of the following are true. Next, question number 17. Let us look at this question. A 3-year boy presents with signs of increased intracranial pressure. Okay, whenever there is an increase in intracranial pressure, we can suspect either an infection, because edema will lead to increased intracranial pressure within the brain, or it could be due to a tumor, because a tumor, anything that is expanding cannot expand in the brain because the skull is limiting it. That's why pressure increases. MRI shows mass in the 4th ventricle. Important, 4th ventricular mass is there. That means it is somewhere in the posterior fossa, isn't it? Histology shows perivascular pseudorosettes. That is the key word given to us. Perivascular pseudorosettes. Yes, very characteristically seen in ependymomas. Ependymoma. In a 3-year-old child, a similar history can also be medulloblastoma, but that will not show perivascular rosette. That can show omerite rosettes, and there will be small round cells that will be there. Okay, so perivascular rosette, very characteristic ependymoma. These are called pseudo rosettes, right? Or there can be even true rosettes. True ependymal rosettes also can be seen in ependymoma. True ependymal rosettes also are seen. Next, question number 18. Neurofibrillary tangles are composed of A beta 42, A beta 40, tau protein, all of the above. A beta 42, yes, A beta 42, A beta 40, tau protein, all of the above. Yes, neurofibrillary tangles. Yes, A beta 42 is neuritic plaque. So in Alzheimer, neuritic plaque is composed of A beta 42. A beta 40 is CAA. What is CAA? Cerebral amyloid angiopathy. That is A beta. Tau protein, yes, that is your NFT. So in amyloidosis, what is deposited? All are deposited. In Alzheimer, all are deposited. But neurofibrillary tangles, NFTs, are made up of tau proteins. Right? Next. 6-year-old boy presents with headache, vomiting, difficulty in walking. Okay, so that means there is some problem in the brain. Headache is there, vomiting. On examination, he has truncal ataxia. See, the moment there is an ataxia and difficulty in walking, cerebellar, query cerebellum is involved, isn't it? Yes, I am suspecting some cerebellum. A midline cerebellar mass is seen. Histology shows small round blue cells with omerite rosette. So another rosette we had discussed, pseudo rosettes perivascular, that was in ependymoma. Omerite rosette, characteristic answer, medulloblastoma. It is a malignant tumor in the posterior fossa in the children, right? Medulloblastoma. It will be a small round cell tumor with omerite rosette. Next, question 20. Okay, let us look at this now. 45-year man presents with seizures. CT shows a calcified mass in the frontal lobe. Histology is as shown below. What are you seeing and what's your diagnosis? Okay, look at these. These are blood vessels which are filled with RBCs also. They are appearing capillaries. These are chicken wire capillaries. Chicken wire capillaries. Anybody, where do you see chicken wire capillaries? Very characteristic in chicken wire capillaries are very characteristically seen where, guys? Yes, it will be very characteristically seen in oligodendroglioma. And even I am seeing some cells are showing this fried egg appearance also. Fried egg appearance also seen in oligodendroglioma. Chicken wire capillaries and fried egg appearance seen in oligodendrogliomas. That is the correct answer. And usually it will be a frontal lobe tumor. Right? Next, question number 21. Okay, let us look at this question. 45-year woman presents with weight gain, cold intolerance, constipation. On histology, her thyroid shows lymphoid aggregates with germinal center and Hurdle cell change. Okay, so clinically, weight gain, constipation, these are suggestive of hypothyroid. So there is a hypothyroid lesion, hypothyroidism with lymphoid aggregate, germinal center and Hurdle cell. This is very characteristically seen in Hashimoto's thyroiditis. Hashimoto's thyroiditis will lead to germinal center formation and also will lead to uh, Hurdle cell. Hurdle cells are the metaplastic cells, which will be also called oncocytic cells, which will have abundant granular eosinophilic cytoplasm. Next question. Question number 22. A child is suspected of familial cancer syndrome associated with thyroid cancer, parathyroid tumors, and pheochromocytoma. Histological examination of the thyroid tumor will show. So, thyroid cancer, parathyroid tumor, pheochromocytoma, I am suspecting MEN, multiple endocrine neoplasia. I am suspecting MEN2 syndromes, isn't it? So, I am suspecting MEN2 syndromes, maybe 2A, 2B. Yes. So, MEN2B most likely. Parathyroid is also involved. Yes, correct. So, now histological examination of the thyroid tumor will show. So, in MEN2, the thyroid tumor will show, which will be their medullary thyroid carcinoma. Isn't it? So orphan Annie, no. Orphan Annie will be seen in papillary. Multiple follicles with capsular invasion will be seen in follicular. Pleomorphic cells with atypical mitosis in anaplastic. Polygonal cells with amyloid. That is what you will see in a medullary thyroid cancer. Medullary thyroid cancer. Next. Question number 23. Which of the following thyroid malignancies cannot be diagnosed on fine needle aspiration cytology, FNAC? Answer, follicular carcinoma. Because for follicular carcinoma, you require to demonstrate either capsular or vascular invasion. That is the diagnostic criteria. Either capsular or vascular invasion should be seen to diagnose a follicular carcinoma. If that is not there, we cannot be calling it as a follicular. That is the reason why we cannot distinguish it on FNAC. On FNAC, I will not be able to see the capsule or the vessel invasion. Next, question number 24. A young male has mucosal neuromas on the lips, tongue, marfanoid habitus, and recently was diagnosed of pheochromocytoma and had a cardiac death. What is the most likely diagnosis? Yes, answer is MEN2B. Mucosal neuromas, marfanoid habitus are features of MEN2B. In 2A, there will be none of these. There will be more of parathyroid hyperplasia or adenomas can be seen in MEN2A. MEN2B due to RET mutation, right? Question number 25, the last question now. Let us look at this question. Histological examination of thyroid tumor is as follows. What is the likely diagnosis? What am I seeing? Look at these. There are papillae with a fibrovascular core, and these are orphan Annie nuclei with pseudo inclusion. Look at this blue arrow. This is your pseudo inclusions. And nuclei are appearing optically clear, and these are orphan Annie nuclei. Orphan Annie nuclei, and there is also nuclear grooving seen. So nuclei are appearing like a coffee bean, grooves. Nuclear grooves are seen. Many other conditions where nuclear grooves can be seen apart from here. It can be seen in granulosa cell tumor. It can be seen in Langerhans cell histiocytosis as well. So this is your classical papillary carcinoma of thyroid. So these were questions from bone, soft tissue, CNS, and endocrine pathology. Any doubts if you are having, you can please ask me, guys. Yes, if there are any doubts, you can please ask me. I can see many of you are sitting into the discussion here. I hope all of you understood the questions. See, look at this. With the current pattern of examination, questions will not be difficult. Questions will be easy. The options are difficult. Many times that is how it will be happening now. Okay, so I don't see any doubts. Okay, guys. So I'll end the session now.